My name is Kelly Withy. I'm a family physician. I grew up in California. I went to medical school at UC San Diego, residency in Long Beach, and moved here right after residency, which was a few years ago. I have done direct care for patients. I did teaching at the residency program, and then I realized that you can help people one-on-one, which is really fun, and you can help people on a broader scale through public health interventions. And so I got my PhD, and now I can do both. Let me turn it over to Laura, and Joey is still working on Vince, right? Perfect.
Hi, good morning, everyone, and thank you for inviting me, Kelly and Joey. I'm a nurse. I grew up in Arizona, and I grew up in a very small town. And so the majority of my healthcare that was provided to me as a child, and actually even through college in Arizona, was provided by nurse practitioners. And so that's the model that I am very familiar with, and that I felt very supported by. So I actually went into public health first. I chose a different career pathway when I was in college and worked for about 10 years. And I wanted the opportunity to work directly with individuals. I felt I needed to become a clinician to do that. And when I looked at all of the different career pathways and the experiences that I have, I felt a calling to go and become a nurse and then become a nurse practitioner. So today I'm an adult geriatric nurse practitioner. Because I started in population health, I kind of went into that again pretty quickly upon becoming a nurse, but I've also worked at a community health center, and I currently also work at a high school providing direct patient care to people. So I should say most nurses, the way they go through that pathway to become a nurse practitioner is a little bit different than me. Most people become a nurse in college, they get a bachelor's degree in nursing, they work for a couple years, and then they enter their graduate program. To become a nurse practitioner is the most common route in our state. You have to go out of state to become one of the other 4 types of advanced practice nurses. So I'm a little bit different, but the standard is you go through a bachelor's program and then you go through a graduate program, and that graduate program earns you that experience, that initial experience in education to become an advanced practice registered nurse. And one of those is a nurse practitioner. Like Kelly said, nursing is a little bit more convoluted than medicine in terms of our pathway, but then the work we do, I think, is pretty straightforward once we end up at that nurse practitioner place.
Do we have Vince on the line by any chance? Looking through everybody.
He's not here yet, but I sent him the information, and then I let him know to contact me if anything.
Okay, so I think the next thing we'll do is we'll just talk about why, well, Laura already kind of touched on why she went into it. So I went into medicine. I didn't know about nurse practitioners, so a different growing up situation. And I decided I wanted to go into medicine a little while after I saw my half-brother being born. I was 12, and my stepmother had a horrible labor after being tired for 9 months. She had a 48-hour labor. She didn't want any pain medicines, although I would say by the end she did want pain medicines. I got to go home and sleep during her labor, but she didn't, obviously. And so she had the baby, and to my 12-year-old mind, he was totally ugly. He came out and he had a cone head because she'd been pushing so long. He was blue because he wasn't oxygenating. He had blood on him, and he had this white stuff called Vernex all over him. And so I thought he was hideous looking. And the doctor held him up till he cut the cord. He gave her the baby, and she said, "He's beautiful." And at first I thought she was crazy. I thought she'd lost it with, 48 hours of pain. And then a few days later, it kind of sunk in that, no, she loves him so much, even though he's so ugly. And he's not ugly anymore. I will give her that. But I decided, it just kind of sat with me that, that was a weird experience. And I realized, I want to do something in life that brings that much love. And so I want to be a doctor. And that was the model I had. And so I went straight through. I went to college, I went to medical school, I went to residency. I went straight through, which is actually not that common these days. People often take a gap year after college to take the MCATs, get ready for everything. They could apply in their senior year, I say, to at least to practice their senior year of college, but a lot of people do take some time off. But I just went straight through. But what's funny in hearing Laura's story is it took me 20 years after going straight through to get my degree. I was pursuing a public health degree, and then I had an opportunity to get a PhD. And so I did that with some NIH funding. But that was 20 years later instead of 10 years before. So we have similar interests in public health as well as medicine. And so that's why I went into it. So that process took me 4 years college, 4 years medical school, 3 years residency for family medicine. If you want to be a subspecialist, it would have taken 1 to, I guess, 4 more additional years. But let me turn it over to Laura about how long each step takes.
So, so for nursing, and I'll talk about the traditional pathway and then also the pathway that I took. So the traditional pathway for nursing is that you enter into a nursing program, and you can either start at a community college, get your associate degree in nursing, and then transfer over to a 4-year university like UH Manoa or UH Hilo, HPU, Chaminade. They all have programs. And then complete a bachelor's degree. Either way, it takes about 4 years to get that bachelor's degree in nursing. We call it a BSN, a Bachelor's of Science in Nursing, BSN. And then after that, you have to pass a national entry to practice exam called the NCLEX. And the NCLEX is a mandatory test that you take after you complete your associate degree or your bachelor's degree. And that's the only way you can become a registered nurse. So you have to take this test and then you become a registered nurse. So first you have 4 years of education and you become a registered nurse. After that, most nurses work a couple years in whatever setting. It doesn't matter what setting it does. You're working in, some people work in public health nursing, some people work in long-term care facilities, home health. About half of our population of new grads work in hospitals, but the other half don't. So that doesn't really matter where you're working, but it is quite common these days for nurses to work a couple years, although it's not required. After that, you have to apply to a master's or doctoral program. And in our state right now, we only have doctoral programs. That's a 3-year education. It's a 3-year education. The first 2 years really focus on the clinical experiences. All of our programs here in our state, you do the first 2 semesters where you're front loading a lot of theory, and then you're doing skills you're developing your skills in simulation and in lab, so you're not seeing patients yet as a nurse practitioner student. And then the following 1.5 to 2 years, you are in clinic, you're being precepted by nurse practitioners or physicians, or the most common type of folks that we preceptor under, as well as continuing our didactic education. So at the end of that 3-year doctoral program, you have competencies in evidence-based practice, clinical skills, clinical reasoning, assessment, diagnosis, treatment, pharmacology, and then you have to take another national certification exam, and only after you pass that exam can you become a nurse practitioner. So we have that initial education as a nurse, and then we have 3 more years of education that prepares us for entry level. In our state, we have a family nurse practitioner degree, which is kind of like family medicine. It treats from babies to elderly folks, women of childbearing age, adults, children, everyone. We have adult gerontology nurse practitioner, both in primary care and acute care. So primary care would kind of be like, the folks that your parents or grandparents are seeing for their regular routine care. and in acute care, that's someone who's going around the hospital and working with patients while they're in a hospital. And then we also have, actually that's all we have right now in our state. And so for me, I took a different pathway because I got a bachelor's degree first. So UH Manoa has a program, you do a 1-year accelerated course to get your RN education, and then you go immediately into the graduate program. So that's usually for people who have really good math and science scores, but got their bachelor's degree in something else. And then they realize they want to be a clinician like I did. And so we only have one program in our state, but they do exist in most other states in the nation as well. That program leads you into, you can become a nurse practitioner, adult geriatric, or family nurse practitioner, or you can get a doctorate in executive leadership, or you can become a public health nurse practitioner. So there's some other options, but we're talking about APRNs today. So you can do family or adult geriatric from that pathway.
Vince on yet? No? Shucks. Okay, we'll have a separate PA call. Okay, so in medicine, the way the school works, you can major in anything in college, but you have to take at least 5 core courses, physics, chemistry, biology, organic chemistry, and calculus. And most people now also take biochemistry and then genetics, possibly anatomy if you can. Each school has different requirements, so you should look on their application requirements, make sure you meet those. Interestingly, JABSOM does not require that you graduate from college, just that you take 7 courses specifically for entrance to JABSOM. The way the medical curriculum works is the first 2 years are more didactic. Well, they're not really didactic. The first 2 years are considered classroom learning. However, the way we do it is 2 half-days a week we have lecture. 2 half-days a week we have problem-based learning, which is meeting in groups of 6 students with a tutor, and you go through cases by sequential disclosure, by which I mean the first page of the case you have, let's say there's a 65-year-old woman who has a cough, and you have to decide, and I've been using that example for 20 years, so now we have more information that you need to think about. So if that were the case, all it would say is 65-year-old woman, Filipino, married, lives in Waipahu, comes to you in your clinic for a mild cough bothering her for 1 week. Okay, so that's all you get. So your group of 6 then says, okay, what do we need to know? What do we know from this? What do we have to check on her? What do we have to ask? And so they say, well, we'll have to know if she's had a fever, of course, if anyone around her is sick, if she's traveled, is it getting better or worse? Is it productive? Does she have these other symptoms? So all together in the group, they talk about what they're going to have to ask when they're in the exam room with a patient like this, which I think is a beautiful way to learn. It's not the way I learned. I sat in lectures 5 days a week. But in this way, you're creating neuronal processes from cough to what do I have to ask to your decision tree. And so they do that. So then they get the next page. This patient has been getting worse over the last week. She feels she has a low-grade temperature. She has not traveled. She has 3 kids in the house. And then they have to decide what else to ask. So the next page, you get her vital signs. So her temperature is 101. Her physical exam, you get her physical exam, and she has crackles on her lung exam, and she's breathing faster than normal. So of course, your decision tree initially would have been pneumonia. Now it would be pneumonia from COVID-19, and you would be mad at yourself for not having gowned up, and you'd be calling 911. Normally, that's not the case. Normally, you would be sending her to the hospital for an x-ray or something, and you would make your decision tree again. And then whatever pieces of the process you didn't understand, you would write down on the board as need to knows. So the need to knows are what you did not know at the beginning that you want to research. So at the end of this discussion, you usually get halfway through the case, so you don't actually know her diagnosis. But one of your need to knows is how you diagnose COVID-19, how you diagnose a pneumonia, what causes pneumonia, how you read an x-ray, all those things. And then they divide it up by the 6 of them. They usually each get 2 what we call learning issues. They go home, they come back 3 days later, they discuss those, and they do the rest of the case. Okay, so that was a long explanation of what they do 2 half days a week. Obviously, 2 half days a week, they're researching that and preparing their learning issues to teach their classmates in that small group. The other day of the week, so that is about 3 days of the week, they do 2 things. They do clinical skills where they learn how to listen to lungs, for example, how to take vitals, how to do the full exam. And they do that in the community with practicing physicians. And the other day they're out in the community doing a project that is serving the community, whether it's going to schools and talking about health careers, or treating the homeless with the home project, or going to Kapiolani and working with kids that have cancer. They do those kinds of things. So it's a very active learning experience for the first 2 years. The 3rd year, they go into the hospitals or the clinics, and they actually do their rotations. They do family medicine, internal medicine, pediatrics, psychiatry, OB, and surgery. So they're actually doing the history and physical. They're presenting it to a physician who then comes in the room and repeats it with them and tells them, and treats the patient and tells them what they could have done differently. And that's how they learn, by doing. Their 4th year, they do a lot of different rotations like that, but they can be all around the country, except right now, or around the world, doing things they're very interested in. And that's when they decide on their specialty. And then they go into the match, which is an automated program where they put in their top choices, the different residency programs put in their top choices, and then the computer matches them. And that's when they go into internship, which is the 1st year of their residency, which is 1 year. After you do your internship, you can sit for your board exam and your license, and you can be a general practitioner if you pass the board exam and get licensed. That is a doctor without a specialty. So that in the early 1900s, that's all we had. We didn't even have internships. But now you can go on to a specialty. And as I mentioned, many of them are 3 years. It includes the internship in those 3 years. And then some of them, like internal medicine, you can go on to a fellowship in a specialty like gastroenterology, infectious disease, pulmonary, intensive care, rheumatology, all kinds of different specialties. And that could be either in 1 year or 2 years after your 3 years. If you want to do a surgical specialty, it's at least 5 years of training. And for much of that training, you're doing the surgeries. Once you learn how, you actually do them, but you're supervised. During that period of time, you're paid probably $50,000 a year about for your residency. And then you graduate, you take your boards, and then you are a full-fledged specialist or physician in those areas. Let's see, I have to go back to what we said we were going to talk about next. The differences.
Oh, do you want me to describe the education pathway? Okay, so it's a little bit similar of a flow, except we don't have residencies during our education process for nurse practitioners, and we've already learned assessment skills because we're already nurses. So we've done that in our bachelor's education. We've had experience in assessing patients, administering medication, following up after medication is administered, so seeing how it's reacting or working, communicating to our teammates, whether it be delegating to like nurse aides or reporting emergent or important information to physicians or nurse practitioners or whoever we're reporting up to. So that all we've learned as a nurse during our nursing education. When we enter our nurse practitioner education, the first 3 courses that we really focus on we call the 3 Ps. So that's anatomy and physiology, with focus on the pathophysiology, or what's happening in certain disease states. We have a pharmacology, and we have, it was on the top of my head, and then I'm going to have to look at it because I'm blanking right now. So we have, oh, and then we have the physical exam. So we have anatomy and physiology, pharmacology, and then the physical exam. So we've learned a physical exam, but it's different when you're diagnosing and when you're just assessing. So you have to be able to diagnose with or use your assessment skills with a little bit more specificity as you become an advanced practice provider. So we learn those, we hone those skills up, and that takes the first year. And then the following 2 years of education, we go through many kind of mini rotations. So we do acute episodic care, we do chronic care. If you're in a family program, you learn the infant and child, that pediatric care. So you take a course, and then you also have clinical. We do women's health. If you're in the geriatric program, then you also learn certain geriatric considerations, and you have specific rotations in geriatric clinics, like a long-term care facility or geriatric practices. And then you have your final 2 semesters really focus on consolidating and bringing that all together, and also developing long-term care plans for patients. And so throughout this, you're also learning how to appropriately assess, diagnose, come up with a treatment plan. You make recommendations for prescriptions, and then through that, you get validation from the provider that you're working with that you're on the right track. And they give you, if you're off on the wrong track, or if you're on the right track, but they can tell that you haven't quite grasped why, they give you those learning opportunities that Kelly had described in those case studies. Although we're doing that during our didactic education, we do a lot of group work to develop those critical thinking skills that Kelly had described as case studies as well. But at the end of that, you graduate. And so I think that's an important distinction. There's a lot of residency and fellowship opportunities in medicine, and nursing stops after that education. However, there are now postgraduate residency programs that are becoming more of a trend. They're not required, but they are becoming more popular. I think a lot of APRN new grads, they feel like they want more guidance in their early career. And so while it's not required, it is something that has been very warmly embraced in our profession. We have a couple different programs in our state. So this is after you graduate. Usually in that first year or 2 years after you graduate, you can make between, let's say, $60,000 and $80,000. And then the average for a nurse practitioner, the average income is between 100 and 120. I'm talking about nurse practitioners primarily. Clinical nurse specialists and nurse midwives have similar salaries. A nurse midwife has this similar education to a nurse practitioner, but their entire focus is for women of childbearing age, and they actually learn how to deliver babies. So they commonly work in community health centers, in birthing centers, and in hospitals, and they assist with the prenatal, the labor and delivery, and the postpartum care for women, but for normal pregnancy. So if you become a high-risk patient for whatever reason, that nurse midwife may still provide care for you, but she's doing it in collaboration with an obstetrician. And so they're doing normal pregnancies. They're not doing high-risk pregnancies. They're not doing, but they are expert in diagnosing that and referring that on. And then a clinical nurse specialist usually works in a hospital or as a kind of like a psychiatrist. They have that. They can get a psychiatric specialty. So they all, we like multiple different terms in nursing. So all of those types of advanced practice nurses make about $100,000 to $120,000 in their career, and they start out just under $100,000 in their first couple years. There is another kind of advanced practice registered nurse called a nurse anesthetist. they have to have emergency room or ICU experience as a nurse. And then they go into a very, very competitive nurse anesthetist program. There are only a few programs in our nation. And then they work in pain management or anesthesia. So because they work in, that's a pretty high, risky type of care. So they make a lot more money. They make, I think, almost $200,000, but it's also a small percentage, and they're very, very specialized and have a lot of education, and do a very narrow job. You know, it's just anesthesia and just pain management.
Do we have a chat? Do nurse practitioners also work part-time, PRN as RNs?
Some do, yeah. Because we're registered nurses as well, and because a lot of nurses have experience in, you know, they've gone to school or they've worked. About half of them work in a hospital, so a lot of them have become really good at their nursing jobs, and so they still will do call-in nursing, or they'll work in some kind of specialty areas, as well as working in a primary practice clinic. So not the full percentage. I think it's more typical that once you make that career transition, you do a full career transition, but there are still some nurses. For instance, one of the nurses I trained at, she was in a pulmonology clinic. She had that as a full-time practice, but she was also had gained incredible expertise in IVs. And so anytime they had really technical or patients that had to have very specific procedures related to IVs, or they had really hard sticks, like a dehydrated elderly person, she would be called over and would assist, because she had some advanced technical skills with that. And so she would come in, just kind of do that quick pickup work and then leave. A lot of nurses also, they'll be a nurse practitioner full time, and then they'll work on the weekends as an RN, or they'll pick up like a night shift or two. So it is common, and because we have to maintain our registered nursing license, our RN, in order to be an APRN, you always have that ability to kind of transition back and forth, or to maintain both careers.
So one of our, so what we're going to talk about next is the difference in the two professions. And in some cases, there isn't a lot of difference. I would say, so listening to Laura, if you wanted to do the things like the surgeries yourself, or deliver the babies yourself, even do the C-sections, if you want to do procedures, so even, let's see, taking off a mole on the skin, or up to taking out an appendix, doing I'm trying to think of office procedures that APRNs are not taught to do. So doing colonoscopies, looking up the colon, looking down the throat, let's see, looking through the nose, taking off the moles, doing vasectomies, and then all the way up to everything in the operating room. Those are things that doctors are trained to do. Nurse practitioners are not trained to do.
There's a few. So like we can do, if we're trained, so we have to get additional training if we didn't get it in our schooling. We can set casts. We can do biopsies. We can do incision and drainage. So if you have like, you know, if you've seen on like, I think it's TLC or Bravo, they have like the Zit doctor where she just pops big oils. So we can do stuff like that.
If that's what you want to do in your career.
That's what you want to do. If that makes you happy. We can do, for women's health, we can insert IUDs or the Nexplanon. So we can do sutures and remove sutures or stitches. And we actually, I think by authority, can do vasectomies, but you'd have to get the training to do that. So I have not been trained to do a vasectomy. So if I had some gentleman come up to me and be like, I don't want any more kids, can you help me out? I would have to be like, I can refer you. So it is very dependent on the education. You can't just do something if you haven't been educated. And there is a lot more opportunities for the procedures, even for the procedures that we can both do. There's more opportunities in medicine, whereas in nursing, you kind of have to seek it out, go to a national conference. But any surgery, we can assist, but the physicians are leading it, and the physicians are responsible for that care. And so if you're, and even more advanced office procedures, we're not doing those. We're following up, but the physicians are doing it.
So basically, you come out of medical school being able to do all of that, and it's just what you're comfortable doing is what makes the decision. So you don't have to get any additional training, and that's because you already had like 4 years additional training. So if you listen to the career pathway, I said medical school was 2 years of classroom, 2 years of in the clinic training, and then you have to get at least 1 year in the hospital, maybe 3 years, maybe 5 years or more. So I would say the major difference is medicine, you're coming out. So want to make sure I'm not misstating this, but I think for nurse practitioner schools, you need to have at least 500 hours of clinical training. Is that right, Laura?
I think it's actually 750. And then we've already had, because we're registered nurses, we've already had some of that when we became a registered nurse, right? And then it's 750 additional hours as a nurse practitioner. And
Okay.
that's not the lab-based work, that's just the direct patient care.
So I would say the major difference is that the physicians come out with more than 10,000 hours of clinical experience. So what Laura said about a lot of nurse practitioners want some additional supervised training is what doctors get by requirement. So if you want to come out being qualified to do everything and then choose your piece, then you want to be a doctor. If you want to come out being able to kind of start your journey and then find your niche and get trained in that, then you want to be a nurse practitioner.
Yeah, I agree.
So it's kind of whether you want to be able to do everything or come out and get more experience. And I will say, having worked with both, the nurse practitioners are often older. Like Laura said, her pathway was different compared to the doctors who just come out who are younger. And so the nurse practitioners have that nursing experience. And actually how I see that played out in practice is nurse practitioners often spend more time with patients because they're talking through a lot of things they learned as nurses, whereas the doctors are more focused on, and this isn't true for everybody, these are gross generalizations, but I would also say the medical system puts a little more pressure on doctors to see people in a 15-minute visit, which is very hard, by the way, to see them and then document everything too. So this is a little bit systemic.
Yeah, and I think there's national research that shows that as well. And I think it's, whenever I show that this study, everybody's like, yeah, I think it's kind of right. So physicians will see, like if Kelly and I were working in a practice together, I may spend more time doing the education. So if either one of our patients has a new diabetes diagnosis, I may get that follow-up visit to say, how are you doing? What questions do you have? I may take more time because that's kind of like where my education, because of my nursing, really focused on. Whereas if there's a couple patients who need biopsies that day, they may all go to Kelly. And so she's doing some more technical skills. And I think and some more procedures, although depending on where that nurse's pathway goes, they may end up acquiring those skills over their career. But I think that is a pretty common trend that we tend to have longer visits, and we manage acute and chronic conditions. But then as there are specific technical needs, I think that's where the practice really changes with physicians and where our differences are. So you see a lot more specialists in medicine, and a lot more the procedures, and then the very, very complicated patients, oftentimes the physicians end up taking them on.
Did you say the different specialties in nurse practitioner? You said peds, geriatrics.
There's peds, adult gerontology, family, psychiatric, which is across the lifespan. So that's kind of like they become similar to a psychiatrist. There's women's health, and there's neonatal, which is in the hospital, and there's acute care adult geriatric. So those are all the different ways you can become a nurse practitioner. And then so that's the base. So those are the certifications you can take, the exams you take in order to become an APRN. And then we can stack on education after that. So there's things like palliative care and hospice certifications and nephrology certifications, emergency room certifications. So you can layer on that education. But as Kelly clarified, that comes after you've finished your initial education, in contrast to medicine, where you front load all that education together.
Okay, and then I know one of the questions is, how do we work together? Oh yeah, how does an MD and APRN work together? And so I would say, in my mind, in my perfect practice, I would have a patient-centered medical home where there'd be a couple doctors, 3 nurse practitioners, a couple PAs, a diabetic educator, a nutritionist, a pharmacist, so that we can each help with that piece of the puzzle. So that if I have a diabetic and I've explained it all to her, but she's just not getting it, she can talk to the nurse practitioner, then she can have a follow-up with Laura, and Laura can take more time and say, what exactly is it that you don't get in here? And then maybe a community health worker can go to her house and see what she's got there and how she cooks. And then when she needs to go on medication, I'll explain it to her, but then she'll meet with the pharmacist who can explain it in more depth. So I see it very nicely. And then when she comes back and needs a mole removed, I can do it. And then when she goes to the hospital, I can follow her in the hospital. So everybody has kind of their area of expertise, and we can really work well together. I think that would be the ideal medical practice. We don't have a lot of those, unfortunately, but we're hoping to go to that.
Yeah, I agree. I think that is the ideal medical practice. And I think what is great is that everybody becomes really good at something. And so I think, so that's a kind of a primary care example. I had a great opportunity to do a rotation at Leahi, which is a long-term care, like a nursing home over by Diamond Head. And there was a nurse practitioner. She was great at AFib, which is an irregular heart rate. She could get patients in control, and then she could taper them down into having the lowest amount of medication to be in control. She's been doing this for like 40 years. So she's an expert. And so physicians would come and say, like, I have this patient with AFib. They would delegate it off to her. And then she'd be like, I have this patient with, something, like a super sticky UTI. It's not going away. And we need to have like some more advanced diagnostics for it. So there's kind of be this swapping of patients based off of, like, this physician was great at urinary tract infections and infectious disease, and then this patient, this practitioner was really good at this other thing. And these are all really common symptoms for elderly people, but they were kind of sharing the burden together. And so they weren't strapped. They weren't feeling like they were having to go out on a limb or spend time like reading through all of the textbooks and the manuals and the journals, trying to figure out the best approach, because they had someone in their team who was expert in it. And I think that is the other benefit, not just with, it's not just delegating patients, but it's leaning on each other and lending each other resources that we have. And I think that's really important. And that's the best models that I was thankfully able to experience when I was in training. But then when I've practiced, I've been able to have some of that as well. And so you're like, I know this person's super good at this. You kind of let them bloom, let them blossom, and your patients benefit from it. And then you have this shared sense of responsibility and shared community. And I think that helps. We talk so often about the challenges of healthcare it can be really draining. And so when you're able to have that kind of supportive, collaborative environment, I feel like it kind of fills your tank up, fills their tank up, instead of feeling like we're in it alone. And so that's the collaborative model that can be so supportive. And then it also helps, like, you know, then if Kelly's on vacation, I know her patients because we have a community, we have our practice in a community setting. And so I don't have to be like, hi, who are you? You know, I'm like, oh yeah, we talked a couple months ago where Kelly mentioned that you've been doing great. And so there's this rapport that you can share, so you can cover each other when you have your own personal needs to take care of.
I agree. It can be a really nice system. And I think the closest we have to it here are the community health centers. But there's so much pressure put on having to see a certain number of patients, and that right now we need it more than ever. So it looks like we've got about 40 minutes. So is that right, Joey? Is that 40 minutes? Are we going to 11 or are we going to 10:30?
We can go to 10:30, but if there's any more questions to be answered, we can keep going for those who can stay. But it's still 10:30.
What is the attrition? Okay, I'll go really fast. What is the attrition rate for NPs compared to MDs and DOs? I can say that in school, the attrition rate for MDs is almost zero. What about in school for NPs attrition rate?
You know, I'm most familiar with the GEP-IN program, which is what I did. So a couple people drop out during the RN year because it's super intense, but I don't think we had anybody who didn't complete the program. So we're about the same as medicine.
Now, burnout is a whole nother thing, and we'll talk about that on a future session, but there's a lot of attrition, I would say, for both NPs and MDs because of the pressure that is on them now.
Yeah.
So we'll leave that one for later. Are there any changes in the horizon to the NP scope of work? Depends on your state.
Yeah, 23 states in the nation have full scope of practice authority, which means that we can do everything that we've been educated and trained to do. It does not mean we are going nuts. So Hawaii is actually one of the first states in the nation. We have some of the best laws in the nation. That doesn't mean that organizations have always adopted all the policies, made organizational policies that match the state laws. Community health centers do really great, and a lot of our health systems have made a lot of changes recently. And I think anytime you're working in a private practice, you're not really having any organizational barriers because everybody's having to go 110% to keep that business going. So it's a good state to be a nurse practitioner. Hawaii is.
All right, let's see here. I tried to copy and paste it, but does the APRN, or do they know other APRNs who work part-time as RNs? Oh, we got that one. What specialties are lacking APRNs and RNs in Hawaii?
For RNs, any kind of subspecialty, so emergency room, ICU, OR, labor and delivery, as well as in the community, we need home health, geriatric, hospice. For APRNs, we actually have a lot of APRNs are getting hired into the specialty practices. And so we don't have as many APRNs as we could in primary care. And but a lot of our education is focused in primary care. And so we need more primary care providers. And part of that, I think, is that we're seeing a lot of systems change right now. So community health centers have had good employment of APRNs. It's been kind of challenging for private practices, but as we see large hospitals like Queens and HPH, Palomar Straub, open up clinics, I think we'll see more APRNs be hired into those primary care roles.
So one of the reasons we need more primary care in medicine too, one of the reasons is that primary care, once you get out of your residency, starts at between 150 and 200,000, but specialty care starts between 300 and 400,000. And so a lot of people choose the higher pay. There's a question here that's actually asked twice by different people. Does the APRN recommend students complete online NP programs? I know my opinion to that, and I know I've voiced it to Laura.
No, don't do it.
I
Do not do it. Do an in-person program. If you're going to move to the mainland, you get an in-person program. You get a program that will guarantee you clinical placements. You don't want to be fighting for your own clinical placements. And in a place like Hawaii, it's very challenging to find preceptors. And so if you have a local school, they have the local relationships and they find you providers who they know are great teachers. All great clinicians are not great educators. And you as a novice, as a student, you don't know necessarily if you're getting a well-rounded education. So it's really important to go to a local program in whatever state. If you decide to go to school out of state, that's fine. But you got to go to a local program where they have strong relationships with their local provider community and they set you up with the best clinicals. The online program, you're fending for yourself and you're a learner. It's not your job to find the best clinical placement. That should be the school's job. And a lot of times when you go to an online program, you end up having to pay extra money to pay the preceptor. So you're paying a lot more money in addition to the private tuition costs that you're paying the school, that you're paying the preceptors directly. So it ends up being a much more costly education.
And I will say I've had a student that was supposed to learn physical exam from one of these online programs, was supposed to learn physical exam from me in a week, with me seeing patients full-time and them working full-time. Here's another difference between doctors and nurse practitioners. I've heard of nurse practitioners going through nurse practitioner school while having a job full-time. Medical school, you can't do that. You are a double full-time student. You are intense studying. Oh, and somebody asked if there's another test you have to take for going to medical school. No, but once you get into medical school, you're taking tests all the time, including boards part 1, which is after your second year, and boards part 2 during your 4th year, and then boards part 3 after your internship, and then your specialty training test every 7 to 10 years.
Okay. Yeah, so with, I forgot what
Anyway, yeah, we don't recommend the online programs. You need to be face-to-face taught a lot of things, and you need to have good teachers.
Oh, my follow-up comment to that was, it is most of our schools now, they are a cohort model, and so they're no longer allowing students to be employed as nurses while they're completing their graduate program. The older model that still exists in some places is that you're not completing your education in 3 years. You just have to complete the course load. So if it takes you 5 years because you're going through part-time, then it takes you 5 years. But I think as programs become, or as programs are looking at their students and their graduation rates, there was higher attrition back in the day when you could kind of spread out your education and also work. And it's also, you have to learn a completely different thought process to diagnose or to follow an order. And as a nurse, you're following an order. As a nurse practitioner, you're diagnosing. And so you have to break those habits. And so I think it's more common now, and actually more important, that you take a break, complete your education, learn this new knowledge, master the competencies that you're working on, and then move forward.
And so there's some excellent questions here. We kind of talked about how we personally chose between being a doctor and nurse. It sounds like in our cases, it's the exposure we had in early life. But are there certain characteristics, traits that are more beneficial to being a nurse and not really for a doctor, and vice versa? And I would say, if you want to be in charge, the one making the decisions, the one giving the orders, the one top dog, if you've got to be top dog, go to medical school. But if you want to be in a supporting role, and sometimes top dog, but not always top dog, and you want to spend more time with people, getting to know them, you can do that as a doctor, but it's easier to do that as a nurse.
And I'll add a different perspective. A lot of nurses, when they're working as an RN, the typical schedule is you'll do 3 12-hour shifts, and that's considered full-time. And then when people decide, they're like, you know what, the 12-hour shifts are getting kind of hard on me, or I want to have kids, or I have small kids and I need a little bit more of a consistent schedule, a lot of time that will be a factor for them to consider the advanced practice route, because you're more commonly working a 9 to 5 schedule. And so there's a different, there's also a different consideration, because to become a nurse practitioner, you've already chosen to become a nurse. I think some of you guys are in high school, so maybe not quite yet. But so if you've already become a nurse, that might be a decision-making factor for you, is that you're trying to consider your lifestyle as well.
And actually, that's one of the questions. What are the key differences in lifestyle between APRN and MD? And you kind of covered it between RN and APRN. So primary care, office-based MDs are similar to that 9 to 5 with nighttime calls sometimes. And that can be the same for the APRNs. For MDs, if you're going to be a hospitalist, you're working 12-hour shifts back to like the RNs. So if you're hospital-based medicine, you probably have shift work or all night, more likely to have all night things. But I don't see that much difference in general between, it depends in your life what you choose to do. So if you want to be a hospital doctor at first, and then you have kids and you say, no, I want to be an outpatient doctor, you can do that. You can go to half-time. Some people like shift work. They work on the weekends. Their husband works during the week. They can take care of the kids. So I think in either of these professions, you can switch to fit your lifestyle.
I agree. Yeah.
Have we ever thought about switching? I have never thought about switching, because I'd have to go back and do a lot of school.
Well, I think because I chose nursing 10 years into my career. I kid you not, I was working in a cubicle for an insurance company, and I had a chart, and I had like nursing, I had DO, I had MD, I had naturopath, my brother's a chiropractor, I had chiropractor, I had PA, and I had listed it out like pros and cons. And I was actually pretty torn, because I feel like there's so many drawing factors for so many of those professions. But one of it for me was that I didn't want to leave Hawaii. And so I had narrowed my choice. I think I would have found a lot of passion and joy in medicine. I think I found a lot of passion and joy as a nurse practitioner, but I certainly love the choice that I've made. I don't regret it.
Are there unspoken or unknown conflicts or differences between MD and APRN professionals? Yes. A lot of family doctors are afraid that APRNs are going to take their jobs. And when we talked about working together, you can see we do a lot of the same stuff. And depending on what you've gotten special training in, you both could get especially good at something. So there is a fear, which is based in experience in many cases, that APRNs are going to take all the family medicine or pediatrics or primary care jobs. And APRNs are paid less, so it makes sense from a organizational structure to choose them. However, we also said they take more time with people, which from an organizational standpoint is less money in the bank. From an individual standpoint, I like somebody takes more time with me. So you can see that this fear is real. This fear has happened, but ideally we would work together to solve this unspoken or spoken conflict.
And I would say from the nursing perspective, I don't know a single nurse who has come in to this pathway to be like, I'm going to squeeze out physicians. I'm going to squeeze out family medicine. I think it's because we have a lot of respect for our family medicine and our physician colleagues anyway. And we also really love nursing, and we see that there is an opportunity to collaborate. And so it always is a little bit painful to hear that, that there's distrust because of the past. The nurse practitioners have very few own their own practices in Hawaii just because of the cost of business. And we do actually also earn a little bit less money based off claims. We don't just have a different salary, but we are reimbursed a little bit less for our patient visits, even if it's the same kind of visit. And so I think there's this, we know that we have to work with physicians because we won't have a place to work otherwise. And so I think we're still, from both sides, we're both trying to find that happy middle ground, because when you start looking at the business side of things, it's always complicated. But there has to be this symbiosis. We have to be able to work together. There is not a future where physicians go away and it can be just nurse practitioners. And I think that's really important. We have to have that collaboration and that symbiosis, at least for us to move forward. And we're growing rapidly. Nurse practitioners are growing, I think, at 6% a year. Because we have a shorter amount of education, but also because there are so many nurses. Millennials, there's like more millennials than there were baby boomers who went into nursing. And a lot of us have chosen to go into the advanced practice route. So a lot of us are looking to this pathway, but we know that we need our physician colleagues.
And I would say it's not on an individual. So there are individual family physicians who fear and dislike nurse practitioners, but I have not met a nurse practitioner that necessarily dislikes doctors. I think the conflict is more on an organizational level, where physicians feel frozen out because organizations, anyway, there is an ideal we've described to you where, we would work together to see the patients. And when Laura had questions about something complicated, she would come to me because I had more clinical hours of experience. And when I needed help getting to somebody, their underlying needs and stuff, I'd go to Laura. So there's a symbiosis, as she said, that I hope your generation embraces. Okay, we've got a chat. Is there financial aid to pursue nursing GEPN programs for those who already have a bachelor's degree? Grants.
Yep.
A good question, because GEPNs come out with more debt than medical students.
We do, because you essentially complete a second bachelor's degree in 1 year, and so you have to pay for those credits. So it is costly. It's about $100,000 for that first year, but it's a whole nother bachelor's degree. It is costly. There is federal financial aid, and there's oftentimes scholarships. And then if you go into public service, you can do loan repayment.
I'm laughing at her because we have this discussion, because now I do the loan repayment for the state loan repayment program. And I have GEPNs who owe more than the doctors, and I'm appalled. But yes, there is financial aid, and there are.
But let me give you a flip. So there are people who also paid off their entire loans. They tended to be local families who were able to live rent-free during their education, and then they didn't work full-time during their graduate education. So I don't think this would happen now, but there are some people who worked as nurses for call-in shifts, so a couple times a month, and they paid off their entire student loans after 3 years. But these are local families who are able to live with their parents or live rent-free, and had some significant family support. I was not so fortunate, but if you are so fortunate to have that support, I think you can make it work for you, and a lot of those local families were able to do that.
Can a pre-nursing student become an APRN instead of going through the ADN and BSN route?
No, you have to get your RN. So you have to complete your bachelor's degree and then you apply, but you can fast track it. So you don't have to work a couple years as a nurse. As soon as you are in your last year of your bachelor's program, you can already apply to the graduate program. And we are seeing that trend more commonly these days, particularly I think with your guys' generation.
Are there as many APRN specialties as there are MD specialties? No, we talked about that. 7 for APRNs. I don't know, like 80 or something.
I was gonna say like 100.
I don't know, they're a lot. You can specialize in the index finger if you want in medicine and just operate on that. Probably not in Hawaii, but in a bigger city. And I forgot to mention the tuition at JABSOM, I believe, is $41,000 now. So when you compare that to the $100,000 for 1 year, and then it's just that 1 year, I guess, in the
about a $40,000 for the rest of the education.
And then medical school is 4 years. So I think private schools are like twice that. So a lot of in-state schools are 50,000, private schools are 100,000 a year for medical school. Jobson is, I think it's 41 right now, which of course does include your living expenses, but it includes all your training expenses. Okay, what qualities and skills make a great APRN?
Oh, well, you have to be a critical thinker. You have to be able to listen. Um, and I think you have to have a real true dedication to lifelong learning, because you're always going to be, your patients are always going to get more complicated. You're always going to see something that's new, and there's always new treatments and treatment approaches, medications. A lot of the other skills, you know, you have to be able to assess, diagnose, and treat. But I think if you're not a good listener, if you're not committed to being a lifelong learner, and you don't have a sense of humility, then even if you can do all these other things, you may not be the clinician that's right for a patient, right? Or a teammate. Like, we work in teams, and so we have to be good team members.
What do you know now as a practicing APRN that you would not have known prior to becoming an APRN?
So much. I didn't really understand. I mean, I grew up with nurse practitioners taking care of me, but I didn't understand all the different nuances of what a nurse practitioner or an APRN can do. I think I also, because I had grown up in an environment with so many nurse practitioners, I didn't understand this environment of getting a job. And I think when we talked about, you know, is there any is there any discord between medicine and nursing? I think in our state there's something else too, which is it's who you know. And so my first job out of college was, or out of nursing school, was based off a preceptor that I had formed a good relationship with, but I wouldn't have necessarily had an opportunity for a first job if I didn't have local education, because I'm also not local. I'm not from Hawaii. And so I think you do really have to invest in the community that you want to work. Apart in Hawaii, I think in other states, there's, you know, you'll see like long lists searching for nurse practitioners, but in Hawaii, there is that good sense of who you know, and that gets you a long way. But you get to know a lot of people during nursing school. And so every day is an interview, and you should take advantage of that.
Are there job opportunities for APRNs in Hawaii?
Yeah, more in specialty. Hospitals are growing. I think there's room for development in primary care, but I think a lot of that is not because of nurse practitioners, just because our primary care environment in Hawaii is challenging. And there's also growing opportunities for telehealth. So that's a really cool new emerging field. And thankfully we have people like Kelly Withy who are trailblazing for us in an inclusive way.
Let's see, does training for medical school carry over into the summer? So the medical students get 1 month off their first summer, and that's the last summer of their lives they get off. They do get 1 to 2 weeks at Christmas time during medical school. And then 4th year of medical school is a very special year because you have about 7 months out of 12 that are required. And so you have 5 months to do exploratory experiences, like go to places where you may want to do your residency or try out specialties that you may want to do. I went to Costa Rica for 6 weeks on a medical Spanish experience, and then I traveled through Europe for 5 weeks or something. So you actually have time then to do things. Some people say it's a waste of a year, but I kind of liked it myself. What's the average salary of a registered nurse versus a nurse practitioner, and how many years of schooling for both? We kind of covered that, but can you do that in a nutshell?
So here's the problem. Registered nurses, you can actually make more money than as a nurse practitioner in Hawaii. It's usually if you're working in night shifts at a hospital, you can make more. And so there can be a challenge making that leap. A nurse practitioner, so a registered nurse, you can make between $50,000 and $120,000. But the $120,000 is if you're working mostly nights and weekends where you're getting kind of bumps in pay, and that's in a hospital setting. You also make a little bit lower money on the neighbor islands. For APRNs, you make between $80,000 and $120,000. You're not going to start off at $120,000, and usually you make between 70 or 80 as if you're in a residency program, because they're doing a lot of additional education for you. So they decrease your pay a little bit in that first year, and then they'll bump it up in subsequent years.
All right. What did you know you wanted? Oh, when did you know? How did you know? We did that. When do you have to decide what area of medicine you would like to practice in? That's during your 4th year that I talked about for the match. So I think it's around January you have to put in your decision. So you have half a year to decide. And that's why you might do, like for me, I did a month of surgery followed by a month of family medicine. And on surgery, I said, put me on call every other night because I want to know if I can do it and not be obnoxious. And then I did a month of outpatient family medicine at a community health center. I said, oh, this is more for me. I can do the vasectomies. I can do the lumps and bumps.
In nursing, when you apply to your graduate program, or
so that was more, and it was more. Go ahead.
I thought you had stopped talking, but my volume just cut out. I apologize. Yeah. For nursing, when you apply to your graduate program, you have to pick your specialty then.
I am going to stop my video because it might make our audio better. Go ahead, stop your video, Laura, and let's see if it makes the audio because you were cutting out. While you're doing that, I'll answer the last question. Regarding the MCAT, how long do you recommend studying for? I recommend studying while you're in school, taking those important classes, and then I did it while I was in school, so I'm not the best one to ask, but I have seen people take off 3 months to do it. Does anybody on the call have advice for others on that? That's a good question for folks who are getting ready to apply to medical school or who just got into medical school. So let's have a panel of medical students talk about that. What were you going to say, Laura?
Oh, I had said for specialty, you have to, to pick your specialty to become a nurse practitioner. You do it when you apply to the program. And I'm seeing a couple other questions. Are you able to become a nurse first and then go to medical school? We've actually had a Surgeon General of the United States who was a nurse first and then went to medical school, Dr. Carmona.
Yeah, I would think you would be very attracted to a medical school if you had experience as a nurse, just as you would be very attracted to very attractive to a nurse practitioner school, because you've shown your dedication to the field of medicine. Because
I have 2 classmates who completed nursing education with me and then they went into medical school.
So absolutely yes. What jobs or volunteer experience do you recommend to expose yourself to the healthcare field? This is an excellent one for that next panel of medical students, because there are so many. A lot of people are scribes. Some people work for the Home Project, which is the Homeless Outreach and Medical Education Project. Some people do research. Some people do the Castle Cope Scholars, some people are medical assistants, actually hired as medical assistants in doctors' offices. They get an excellent insight into the field. So there are many ways to do this. Definitely ask your mentor at Pre-Health Career Corps to set you up with shadowing experiences and other volunteer experiences. I think we got through all the questions. Any other chat questions or any questions I missed?
Oh, there's one more. Are you able to become a PA if you have an RN? I think that's the case because it's the graduate program. So if you have as long as you've completed the prereqs, you could become a PA. You know, you could be admitted to a PA program.
Definitely. And from these questions I got, we're going to have a couple future sessions. And actually, everybody on the line, feel free to email Joey or anybody at Pre-Health Career Corps about other sessions you would like to have. But what I see here is we've got to have our PA on. We'll compare that to MDs as well. And I think you'll hear a lot of similar things. And also maybe a panel of a few medical students who are about to finish and can tell folks about their experience applying to medical school and how long to study for MCATs and stuff. That sound good? And then, yeah, if you want to send out a note to all the PHCC students and ask what seminars they would like, we can do that. Even Julia could put it in the newsletter.
Yeah, I can do like a open call if we're to say, yeah.
Any last questions? All right. Thank you guys. And let us know your questions. We're always here to help. And thank you for social distancing and washing your hands to protect your parents and your grandparents and me, because I learned there are 2 people in the ICU at Queens who are younger than me. And so thank you for protecting me by washing your hands all the time and social distancing.
Thank you everyone again.